I'll just quickly introduce Dr. Paul to everyone. So first of all, I just want to say a huge thank you to Dr. Paul for joining us today. He's actually taken a day off, so he
Um,
could be with us. I hope you don't mind me sharing, but his son's also drafting tomorrow. So I think it was an opportunity to spend some time with him as well. But we really, really appreciate you taking the time to speak to us. Just a little bit of a background. Dr. Paul is a consultant cardiologist from the UK, and he's been practicing in Israel for just over 10 years now. He's got clinical interest in both coronary artery disease and cardiac prevention. In essence, he's now trying to prevent what he treats. He's the clinical lead for cardiac rehabilitation prevention at Shamir Medical Center in Rishon LeZion. He's a senior interventional cardiologist and runs a cardiometabolic service where he takes a holistic approach to metabolic dysfunction or dyslipidemia, focusing on early disease detection, risk stratification, and intervention with both lifestyle changes and medical therapies in order to prevent the onset and complications of atherosclerotic cardiovascular disease. He says, and I hope this is still the case, that he's excited to share his thoughts with us today, especially as nutrition is fundamental to his clinical practice. So thank you again, and I'll hand it over to you, Dr. Paul.
I'm taking a different seat so you don't have to see the coats in the background. How long have I got, by the way, just so I can time myself appropriately?
So,
You have as long as you want, really. Generally, I mean, our meetings can run up till 10:30 in the morning, but as long as you want, so don't feel rushed. And if you want to leave some time for questions at the end, that would be amazing because I'm sure there will be many.
Yeah, no, definitely. I really want to leave time for questions, and maybe if this goes okay, you'll have me back because there's so much to talk about. The actual I've worded the title about what's in the pipeline. That in itself is like another whole lecture. So I've summarized what's in the pipeline, but that could be an opportunity for a future talk.
We would be
But
so grateful for that. Thank you so much.
yeah, no, it's for me. This is taking the day off is the easy bit because I'm due holiday as always, and I think this is a really important message to share because really what I and many people in the sort of atherosclerosis community are trying to do is change what for me is a very simple concept, but it's made far more complicated. As often we do in life, we take something that's simple and unfortunately make it more complicated than it needs to be. And I'll explain that as I go along. Let's see if my slides will go ahead. Okay, so really, when you look at this busy picture, all it's saying is that, in that area where we can preserve health, we should be doing exactly that. We should be enjoying our lives, investing in our future, and avoiding treating a disease because by definition, we've missed the boat. Once we treat a disease, it means the problem has arisen. I say to patients in a very, I try and make this very practical. You wouldn't, the most sensitive thing we have is our children. So if your child is going to borrow your car, and we're all of that, and many of us are that age where kids are now driving, which is, quite frightening in when it first starts. But if they say to you, the car's got some smoke coming out the bonnet, we're just going on a trip now to Rosh Pinah, is that okay? You say, yeah, sure, no problem. When it blows up, call me and we'll fix it. And that's fine, we'll do that. And your son will look at you with kind of like, as my father finally lost the plot. But that's what we do with our bodies. We say, well, look, it's all right. You don't need to take tablets. Whatever. It's a pain. You don't need to do these things. Wait till it explodes. Wait till you have a stroke or a heart attack, and then we'll fix it. It's all good. And that's the concept that I really have problems with. I want to try and address. And this picture is just saying that. What it's saying is that you're born with your genes, and then you have maladaptive or even adaptive responses, but it's based on cumulative exposure to pathogens and risk factors. And once they accumulate after a certain period of time, the disease manifests. And that's the period, the window that we in essence miss. So preventative strategies are initiated too late, in my opinion. And just to sort of go through the themes of the lecture, I won't keep to these exactly, but these are the sort of things I want to talk about. I think it's really important we discuss the pathophysiology of coronary disease because that helps explain the treatments and why we need to do them earlier. What is it about LDL, this cholesterol hara, as we say to patients, the bad guy, the LDL cholesterol? Why has it become so complicated when it just really doesn't need to be? And how we should be managing it, and then a little bit about future therapies. And before we do that, I want to give some case examples because I always think they're the best ways. Now, just to expand on Aaliyah's introduction, I started off as an interventional cardiologist. That's what I do because, you know, I clearly have a big ego and I wanted to be that sort of, you know, showstopper when you're around at people's dinners. I'm an interventional cardiologist. There is a lot of ego in it. There is, but there is also a lot of good in it. You have this ability to treat someone in the midst of a heart attack, and it's one of the most satisfying things you'll do as a person, I think. Take a patient who's on literally the depths of dying, and then half an hour later they are literally drinking a cup of tea. So it's a great thing to do. But along the journey, I've realized that we really are quite crazy and that we could prevent a lot of this from happening. So that's why I say I'm actually quite happy to prevent what I treat. And these are case examples which help illustrate why I've moved more into the prevention field. So say we've got here a young lady, 45, who's got a normal BMI, except BMI has limitations, but a normal BMI. And the daytime blood pressure is high, 145/82. Now, the current guidelines sort of say your blood pressure should be less than 130/80, really closer to 120/80. That's the sort of textbook blood pressure. What would you like my blood pressure to be? I'd say I'd like it to be 120/80. But we know that, you know, coming to the office, people are frightened. It's not an accurate measure all the time. But this patient's had consistent workup, and a blood pressure is around about 145 systolic, so it's elevated. Now, this patient is asymptomatic. It was only found out because she was going to the gym and someone measured it, and that kind of example. And for some reason, she's actually had very extensive imaging of her brain. So she's had a normal CT scan, ultrasound of the arteries in the neck, the carotid Doppler, and ultrasound is normal. And don't ask me why, she had an angiogram of her cerebral arteries, and they're all absolutely fine. So how would we treat this patient? Would we say, you know, conservative lifestyle? Would we start treatment? Or we actually wait for a stroke and then say, right, now the problem's here, let's fix the problem. And we'll come back to this later. I just want you to think about that. Conservative, start treatment, or wait for the stroke. Similarly, another patient, again, this young female, but it could be a male, either one. BMI, okay, no diabetes. This is the mean LDL, 153. Triglycerides, 154. Okay, nothing screaming out there. A lot of people would say there's no FH, more than 190, familial hypercholesterolemia. And the risk is low. They've got no family history, non-smoker, completely no symptoms. Exercise test is fine, no ischemia. Again, what would we do here? Conservative lifestyle interventions? Would we further risk assess? So cardiologists have these scores called the SCORE, or the pooled cohort equation, where you type a load of variables into a computer and it comes out with a figure which tells you what tells you what their risk of having a bad thing in the next 10 years. Would you start lipid lowering therapy, or would you do some imaging? If not, would you wait for the heart attack and then treat? Another question. So we'll come back to those later. Now let's set the scene of cardiovascular disease. Cardiovascular disease is an umbrella that embodies lots of diseases. It can be congenital heart disease, it can be cardiomyopathies, but the bulk of cardiovascular disease is atherosclerotic. So disease coming from the coronary arteries. So we call it ischemic heart disease, coronary heart disease, atherosclerotic, lots of different terms, but let's think about it as disease of the coronary arteries, coronary artery disease. Now, in 2019, the figures were roughly saying about 19 million people worldwide died from cardiovascular disease, which is more than the next three combined. So cancer, chronic respiratory disease, and diabetes. So it's a pretty big problem. Now, I've been talking for 6 minutes, which means 2 people have died from a stroke in America as of now. And in 40 seconds, do the math, someone's had a heart attack or stroke every 40 seconds. That's quite a few times in this short period of the talk so far. And these are only getting worse. So this is for future projections of all the risk factors for cardiovascular disease, diabetes, hypertension, dyslipidemia, obesity, and MI and stroke. They're all on the increase. So yes, I know I'm bringing plenty of gloom to this meeting, but hopefully at the end, some cheer. And if you look at diabetes, projections in 2050. So now there's about 8 billion people in the world. In 2050, there'll be almost 10 billion. And look at where we live in the Middle East, projected to be a 96% increase in the rates of type 2 diabetes. The Lancet paper here suggests that there'll be 1.3 billion people with diabetes in 2050. So diabetes is one of the risk factors we all are aware of as the classic panel that we screen for in patients with cardiovascular disease. So we look for high blood pressure, smoking, dyslipidemia as well. Dyslipidemia is high cholesterol, high LDL cholesterol, high triglycerides. And this is the cocktail of risk factors we screen for in every patient. But really, it's like sort of saying, well, hold on a sec, you've got a house and it's got no roof on and the rain's coming in. The rain is the risk factor, but what causes the house to fall down? There's rot, isn't there? That something sets in a disease process. And that's what I want to sort of turn to today. Cardiovascular disease is really caused by three disease entities. So we have endothelial dysfunction, inflammation, and oxidative stress. Sounds very technical, but I'll go through them. They're actually, it's very straightforward. So this is endothelial dysfunction. The inner lining of the coronary arteries, all of our arteries, are an incredible equilibrium of yin and yang, procoagulant, anticoagulant, vasoconstriction, vasodilatation. They keep everything to a perfect, sort of level. But if you upset those with the risk factors that I mentioned, you get endothelial dysfunction. So things are now askew. You have more coagulation against anticoagulation. And that's endothelial dysfunction, disruption to the inner lining of the blood vessels. Oxidative stress, so oxidation, like free radicals. So your cholesterol, LDL, can enter into the intimal space and becomes oxidized and becomes a different beast then, much more pro-atherogenic. And at the end, this is a nice picture that we use now called OCT, like you do for the eyes. We can image and size the arteries. And you see here, this is a rupture of a plaque. This is what causes the heart attack. The plaque ruptures as a result of these processes. And you can see them again here. So this inner lining, you see my arrow says intima. So this is the intima, which should be an intact layer, nice and clean without disease. And you see the yellow arrow pointing to an LDL. So the endothelial dysfunction allows the LDL to pass in. Oxidation allows it to be oxidized, taken up by this macrophage. And then inflammation is where you get this. It's almost like a spot, it's like an inflammatory mass within the inner lining that involves both your innate and your adaptive immune system. So your first line of defense, the innate, and then the antibodies which come in to help. And eventually, this is the plaque rupture that I showed in the last diagram. And it's the thrombus on top of that blocks the artery and causes the heart attack. And I show this very slide to my patients, and I say that, this is a progressive disease. In the 20s, we see atheroma, unfortunately. And in the 40s, it's definitely there, especially in men. And the average age for a heart attack often is around 64 for males, and that's where you have this significant plaque that ruptures and causes a heart attack. So these three processes are what I think are very important. And inflammation is really, really an interesting phenomenon because it's happening all the time. Even something simple as gingivitis causes something that we recognize as systemic chronic inflammation. You see that middle wheel here. And what's driving that middle wheel? Well, processes that you'll recognize for sure. Physical inactivity, obesity, your nutrition, obviously very relevant to yourselves, but even things like that became more relevant during COVID. So isolation, chronic stress, disturbed sleep. These are things that happen to us every day. We just take for granted. Doc, does stress come into it? Does stress? And I said, of course it does. I used to say to them, I can't say how, but for sure, stress is a relevant risk factor for coronary artery disease. And now we can understand why, because it drives this wheel of systemic chronic inflammation, low-grade chronic inflammation. And the outcomes of this are bad. They cause what we term as the four horsemen, the four diseases that claim most of our lives. So what are they? So metabolic diseases, type 2 diabetes, fatty liver, all these inflammatory processes that result in metabolic syndrome, the likes of which I'm sure you guys see on a daily basis, cardiovascular disease, and cancer and neurodegenerative disease. So, things like low-grade inflammation, smoking, obesity are huge risk factors for cancer as well, which people don't appreciate. And neurodegenerative diseases, things that we would hope would never happen to any of us, really horrible, chronic, debilitating diseases. So inflammation is a target of our therapy. Now, our current practice really doesn't involve any of what I was saying before. You see the problem, you fix it so the car doesn't break down and you're left on the Kvish with a broken car and, God forbid, no accident to anyone that was involved in it. But what we do is we wait. Someone here reaches this stage. So say, let's take the average male, 64. He comes in with a heart attack and then we fix him and put a stent in and everyone's like, wow, you're amazing. Thank you so much. But we've really missed a huge window because that plaque has been there for decades. And we can see these plaques, and I'll talk about this. We can see these plaques and we can treat earlier. So this is something that we're really missing. And you may hear this talk about coronary artery calcium score. What is it? It's very important to explain this because it has nothing to do with dietary calcium. We've mentioned this theory of inflammation. So as the plaque, which you can see in the top, is being deposited, this yellow atheroma within the wall, it's an inflammatory process. And calcium is part of that. Calcium deposition is part of that inflammatory process. So what you can actually do is measure calcium within the arteries and come up with a calcium score. This is somebody with a very high calcium score. You can see the bright signal of the calcium, and we can grade it, as you see on the left. The best thing is to have none, but you can go in sort of steps from mild, moderate to severe. And that's something that we do. We talk about the coronary artery calcium score as another way of risk stratifying, because if it's there, you've got the atherosclerosis. So what's the scale of the problem? Well, here, there's a few slides just to show that it is a real problem. This is data from patients who received heart transplants. So you're now following the heart of the donor, and these patients are typically quite young. So these were young patients donating the heart, and then what they then did was look at the recipient with IVUS. This is an ultrasound picture inside the arteries of the donor. So the heart comes with the donor arteries, and you can look to see if there's any evidence of plaque. And these people range from age 13 to 50. And you can see that in patients as young as 13 to 19, 17% have evidence of atherosclerosis, which is shown here on the right picture, this thickened layer of intima that you can see with the camera. So it's happening in young patients. We don't appreciate that. This is a screening study. This is a screening study of a large population in Sweden, often regarded as a healthy population. And these patients underwent a CT scan. These are patients without coronary disease, healthy people from the street, you can kind of say, age 50 to 64. A lot of them female, which is good because they're often underrepresented in trials, women. And you can see here that 42% had evidence of coronary disease from the CT study. Quite frightening. Men more than women. 5% of these patients had a stenosis in the artery of more than 50%. No symptoms, just taken off the street, a random CT scan. And on the right, you see that women have a sort of protective effect. So what you see happening in males 50 to 54 was only happening in women aged 60 to 64. And all these pictures just show that with time, the disease gets worse. Here's another study of primary screening, patients without coronary disease in the United States. This was done between 2015 to 18, so about 2,500 patients, a lot less than the previous study. But again, asymptomatic patients, they went for a CT scan and look at the calcium score. You see 42% had a calcium score more than 0, and 58% had a calcium score of 0. Of the total population, 49% had coronary disease. 49, so 1 in 2 basically had evidence of plaque. And 6% had a stenosis more than 50%. 7% had disease that showed a high-risk feature within it. And then what about the people with coronary artery score of 0? So the calcium score is 0. These are low-risk patients. Surely they've got no calcium in their arteries. Well, again, 16% of them had evidence of plaque. So this is, quite frightening to know the disease amongst us and we don't know about it. So why do we have a problem? Why is there a problem? Where are we going wrong? Well, let's first of all start with the basics. So I think in Israel, we all agree the screening and the primary care is extremely impressive. I mean, patients come to me on Maccabi. I can get an incredible amount of information of all their blood tests with trends dating back to the first one. I can look at the megama, the way it's changed over time. So patients go for an LDL blood test and the results come back. And this is just a random blood sample I got off Google. But look at what it's saying here. The LDL is 145. And the triglycerides are 190. So someone will look at that, the patient, and say, well, look, it's supposed to be less than 130. I'm only slightly above the recommended limit. Not so bad, not so bad. And let's look at Maccabi. This is a patient of mine. His LDL is 163, recommended less than 130. Triglycerides recommended less than 150. Where are these numbers coming from? They definitely don't represent any medical paper. They are random numbers, and essentially what's happening is they're trying to one size fits all. Here's Clalit, for instance. Now they're slightly stricter. They say the LDL recommended less than 100, but again, where's this coming from? There is no trial that shows this is the recommended number. So what's the whole issue behind it? Why am I fussing about it? Why is it so important? Why do we need to have it low? Well, this is a busy slide, but essentially it's just a meta-analysis. It's a collaboration of many trials put together. So, 90,000 patients, 14 trials. This is the first of a major series of papers that were published in the Lancet. And essentially what it's saying is in these patients, these are primary and secondary prevention. If you lowered your LDL And they give it in the European units of 1 millimole per liter, which for us is about 40 milligrams per deciliter. So if you lower it by 40 milligrams per deciliter, you're roughly getting a 20% reduction in major vascular events and a 23% reduction in major coronary events, things like heart attack and death from coronary disease. So these are really big, hard outcomes. But again, look below. Every 40 milligrams per deciliter, you're reducing death by 12%, cardiac mortality by 19%, stroke by 17%. And amongst these trials, in blue are the primary prevention ones. So there's a mixture of two, and it's still consistent in these patients as well. Major vascular events reduction by 12%, reduction in death, all-cause mortality by 9%. These are very serious reductions. And then the next paper that came out, this was 2010, this is about 5 years later, they then included studies where we went more radical. We lowered the LDL even more. So this was at a time when a big paper came out saying that we now need to get the LDL below 70. We started to use Lipitor 80. It was a huge change. Nobody could believe it. People were like, we can't do this. We can't, surely. But when we include papers that did this more aggressive approach, you got an even bigger benefit. So you had a further reduction in hard outcomes, including mortality. And this is a paper that I really want to spend a couple of minutes on. It's super interesting because to me, I get a lot of, have a lot of conversations, could be at work, could be in school, could be anywhere. What's the evidence of that? And I am not one of these cardiologists who can obliterate you with evidence-based medicine. Far, far from it. They're a lot better than me. But I tend to hang on to something which for me is very, very real. So this is a study looking at genes, genetics, because when you're born with a gene, that starts from year zero. Okay, it's there from birth. And in the theory, it's the cleanest randomized control trial you do because you either got the variant or you don't have the variant. So this is a large collection of patients from America, from 4 cities. I think this is from the ARIC database. So the four cities in America. So they took these patients and they said, okay, amongst these patients, we know there is a mutation that affects an enzyme called PCSK9. Now, PCSK9 is a bad guy. It interferes with LDL receptors. So these are Black patients within the study, and the number there is above 3,000 patients. And amongst those, there's a small amount, 2.6%, who have this mutation of this enzyme called PCSK9. And essentially what it does is it makes the PCSK9 slightly, inoperable. And that lowers your cholesterol from birth because PCSK9 is a bad guy. It interferes with cholesterol metabolism. So keeping it simple, 2.6% of Black people in this large population of patients have a mutation which gives them, because it's there from birth, a lower lifelong level of LDL cholesterol. And you can see that compared to the Black people without the mutation, these are above, they have a mean 28% reduction in LDL. Okay, it's not huge, 28%, nothing major, but it's from birth. Now, when we follow these patients through for 15 years and we look at the incidence of coronary heart disease events, so bad things happening to the heart, they have a 90% reduction in these events. From a lifelong reduction in cholesterol, not so huge, 28%, they have a 90% reduction. What about white people within the study? Well, they also have this mutation, slightly more, 3.2%. So there were about 10,000 patients, white patients in the study. They have this mutation, but it's not quite as strong. So they have a 15% mean reduction in LDL. So they have a variant which interferes with this enzyme, which is the bad guy. And they have a lower level of LDL from birth, 15%, and they have a 50% reduction in coronary heart disease events. So I think we all know that patients who are born with familial hypercholesterolemia, very high LDL from birth, they have a super high level of heart disease events. Patients now who have the opposite, have a lower level of LDL from birth, have a significantly less. So I've shown you papers, a meta-analysis where we give drugs to lower LDL. They were older people in their 50s and 60s. You get a significant reduction in events. And here I'm now showing that a lifelong reduction in LDL also has significant reduction in hard events. Again, a similar paper here. This is some slightly a lower amount than the number of patients, healthy individuals, 5,000. We looked until the age of 40, looked at their LDL sort of as a time under, as an area under the curve. So LDL according to age. So we're talking cumulative exposure, not one time point LDL, but looking at the LDL over 40 years and then putting them into quartiles, lowest to highest. And when you follow these patients through, no surprise. On the left, on the y-axis, you'll see cardiovascular disease events. On the x-axis, or the other, you'll see age. And basically, the higher the quartile of LDL exposure, the higher the event rate was. cumulative exposure of LDL causes bad things. So what is a normal LDL? Okay, well, that is probably one of the commonest questions we get asked. And again, it goes back to this sort of information on the blood test result, less than 130, less than 100. I don't know what that means. I don't know where it's come from. So if we take a step back, animals, all animals apart from humans and pigs have low LDL levels. Okay, rabbits have 0 LDL. When we're born up to sort of age 12, we have super low LDL. People say, oh, you need cholesterol for cell growth. You do, but your cells make cholesterol. LDL cholesterol, on the other hand, isn't what you need in high levels. You look at this as pictures of the Siman tribe in Bolivia. These are hunter-gatherers, so they have much more, purer lifestyles. Their average LDL is about 90, and they have no coronary calcium. They have no cardiovascular disease. They are immune from cardiovascular disease. And then you look at US adults, which could be Europe, Australia, South Africa, England. It's all in that group. And you see that from about the age of 10, we rocket out of this normal range, which I put down as 30 to 70. Other people in this area say 20 to 50. People are shocked when you say this, what, LDL 20 to 50? But that's what the normal range is regarded as. And you can see here that on the right, I put a box there to sort of expand this US, European, Israeli data, showing really what are LDLs, how they grow with time. And you can kind of look at that middle box here. I hope my arrows are working. 40 to 49, the average LDL is about 125 milligrams per deciliter. I was 48, I think, when I sort of took on a healthy nutrition lifestyle, lost some weight. And at the end of that weight loss, my LDL was about 140, kind of average, and that was after 10 kilograms weight loss. So here, what am I looking at here? Again, this concept of cumulative exposure. So I know it looks busy, but let me walk you through it. So you see here age on the bottom axis, and on the left here, you see cumulative exposure. So you see with time, you get exposed to the LDL cholesterol. That's this blue slope. So if I'm looking here at the age of 40, the average LDL, I've already said before, is about 125 in American, European data. It's an average, not everyone. Some might be 110, some might be 160, but the average is roughly around 125. So if you do a simple score, 40, which is the age, times 125, you come out to this score of about 5,000 milligram years. So this is your cumulative exposure. And I've kind of tried to correlate it with a timeline of atherosclerosis because you don't tend to see much atheroma here. By the way, I was saying to a patient yesterday, if someone comes into a hospital now with a heart attack age 40, no one really bats an eyelid. It's not really regarded as crazy, maybe a little bit. 45 to 50, no one will bat an eyelid. 40, you may get a little bit, but it's not something that would make people go, wow. Certainly not the morning meeting. No one will be making a fuss over that. So from the age of 40, certainly in males, your risk of heart disease starts to go up much more significantly. And that's what the right axis here is. So your cumulative risk of MI kind of doubles with every 10 years. So the LDL accumulates, and what we say is the average heart attack is around 64 for a male who had an LDL at the age of 40 of 125. So if I see someone in my clinic and they're 50 and the LDL's, 120 or 130, I kind of think they're on this timeline. So I say to them, look, the average age for someone like yourself is 64. Now, I'm not saying that's going to happen to you, God forbid, but that's what we're working towards, preventing that from happening. And I'm following, the blue line in the middle is what we've just been on. So 64, the average age of the heart attack. If he was like one of the patients from that study I showed you, and they had that variant, which lowered the LDL from birth, the timeline suggests that you'll have your first heart attack at the age of 100. But some people might say, well, that's not so bad. I don't mind having a heart attack at the age of 100. We may get to the point soon where people say, I don't really want a heart attack at the age of 100, but you certainly prefer it that than 64, because 64 is often the age you want to retire. And like I said before, people with familial hypercholesterolemia, they are born with very high levels of cholesterol. They start having heart attacks in their 30s, sometimes even younger, if they're born with homozygous FH, so genes from both mum and dad, and they have LDLs of 500, 600, they have heart attacks in their 20s. So to me, going back to what I was saying, I'm not the number one cardiological epidemiologist. I'm not by any means someone who can regurgitate trials. I've really, with time, a decreasing memory capabilities, but anyway, that's another subject. But I remember certain key papers and concepts. And to me, there's a very clear pattern here that too much LDL causes disease. Genetic protection lowering LDL from a young age prevents disease, and the trials support this very, very, very convincingly. I'll maybe add in at this stage that we all have an auntie Millie who lived to 100, had an LDL of 200, and the coronary CT was normal. How do I explain that? I can't. I actually can't. These people have, what I say to patients, other things going on, other sort of systems in play, protective systems that we just don't know about yet. But it's a similar thing to, you know, some granny who smoked 40 cigarettes a day and got to a ripe old age of 95 and never had a problem. These patients exist, but they are the what's the word? The exception, not the rule. So how do we lower? So this is important. How do we lower? We've got lots of drugs now which lower, and I'm trying to put this into a nice sort of picture and to make it user friendly. You can see here lots of different mechanisms how they work. So let's see if this works. So yeah, so we're looking at drugs that start with the statins. So people here, Lipitor, Crestor, they're often called Litorvil, Stator. These are all drugs which work on this pathway here. And it's an enzyme called HMG-CoA reductase, and it inhibits this enzyme. So in the liver, you get less cholesterol made. Now, that's not why your cholesterol goes down. The liver gets in a panic and says, whoa, there's no cholesterol here. Bring some in, bring it in from the blood. So they need to bring it in from the blood. And before I show how you do that, these other drugs do the same. So people have heard of Ezetrol or Ezecor. This inhibits cholesterol absorption from the gut. So it's not as strong and potent as the statins, but it works nicely, especially with the statins. So that also reduces your intrahepatic cholesterol levels. Then you have these other drugs, which are the injectables, which are much stronger. So you may have heard of them. You may have patients on them. The trade names are Repatha, Praluent, and you've got the new guy called Leqvio, which is the twice-a-year one. So these are all injectables. They work on the enzyme I mentioned before called PCSK9, which is the bad guy. And you have newer ones that are coming out called bempedoic acid, which works just higher up than the statins. This will be coming to Israel very soon. Now it's already been already started. It's already on its way now. And what they do is they make you increase the number of receptors on the liver. That's really how all these drugs work. You increase the number of receptors. Now you can pull the cholesterol, the LDL, out of the bloodstream and replete the lower levels of intrahepatic cholesterol. So all these drugs are doing the same thing, increasing LDL receptors. So if you are taking a step back, thinking about homozygous FH, where they have a dysfunction of the receptors, they can't make receptors, so they're often immune to these drugs. That's why they're so hard to treat. But for the rest of us, you increase the number of receptors, you lower the cholesterol in the bloodstream, the LDL cholesterol. And these are the drugs that we have. So statins, you have the Ezetrol, these are the injectables, and fibrates, not so. I just wanted to bring that in. They work slightly differently, but many of you may see patients on these bezafibrates, fenofibrates. These are drugs typically used to lower triglycerides, but they also do lower LDL a little bit as well. And don't worry about this slide. This is just to show you what the future holds. A number of therapies coming, both pharmacological and nutraceutical. So there's lots and lots. It's a really rapidly growing area. So what is my kind of practice? Well, obviously, I couldn't give this talk to you without mentioning the important things. It's not just the cardiovascular risk factors, which is sort of the bottom left here, the smoking, blood pressure, dyslipidemia, and diabetes. But obviously, we've got to address those risk factors that are showed in that diagram about chronic inflammation. So sleep, I don't know about you, that's a hard one because I'm guilty of it as well. None of us sleep enough. Watching Netflix in bed is probably one of the worst ways to go to sleep. But how important? I mean, you know, nutrition combined with physical exercise. And you know, I don't tend to pretend to be but on past experience, given that I did have problems with obesity as a child, I try and talk to the patients as a person, not just as a doctor. I tell them really my say, look, I haven't got time to go into, especially in clinic and hospital, but the Mediterranean diet is something I really believe in. But combined with exercise where you don't have to kill yourself, going outside, walking with your husband, wife, children, fast walking, it's all good. It's so important. And, you know, in my clinic, really what I'm trying to do is, you know, combine these issues of CKD, chronic kidney disease, diabetes, overweight and obesity, blood pressure, dyslipidemia, and sort of because they impact on the heart, I kind of see this as something that I want to get involved in. And I've shown you this picture before. Instead of putting in the stent, what I really like to do is define this subclinical atherosclerosis, because I'm now looking at that window before, And we can see it with imaging, go back to the analogy with the car, the smoke coming out of the car. We don't just ignore it. We take it to the garage and he looks inside. He looks for the disease and then fixes it. It's not rocket science. But really what I'm doing now as well is actually trying to prevent what's called primordial prevention. Let's stop the risk factor from becoming a risk factor. Let's treat it early. So this is a patient I saw in clinic, 47, absolutely no chest pain for sure, no chest pain at all, but he had metabolic syndrome. You know, a religious guy, so he's spending a lot of time learning. And I think in his opinion, there wasn't time for exercise. He just didn't have the time. That could be someone, a religious scholar, it could be a doctor, it could be anybody, because we often prioritize work over what we should be doing, our own health. And I did a CT not to look for a tight stenosis, to look for subclinical atherosclerosis. And lo and behold, he had a subtotal occlusion of one of his arteries. So he got a stent there. It's an unusual story. You don't often see this, but it just shows that, you know, there is significant disease within asymptomatic patients. And when we look at, you know, history in trials, this is a mega important trial. You know, one of the blockbuster trials called the Interheart study, looking at what are the commonest causes of acute MI around the world. And there's really 9 risk factors that include things like psychosocial, absence of good food, vegetables, alcohol, etc. But obviously focusing on the main risk factors, which, you know, we talked about high blood pressure, smoking, diabetes. And really what they found in this study is that smoking and dyslipidemia were the biggest risk factors for MI. And if you treat all these risk factors, you can significantly reduce your risk. And you see here that when you combine all these 4 risk factors, which is dyslipidemia, high blood pressure, smoking, diabetes, the risk is enormous compared to them individually. So the data shows very clearly, you know, for me, dyslipidemia is the big one with regards to heart attacks. And my boss at the moment, he taught me this when I was in a different hospital with him. He always said, it's very funny. So, you know, lipids really is what affects the coronary arteries. Blood pressure is really the stroke, the neurologist area, and smoking is often the peripheral arteries, the vascular surgical area. And it's quite a nice analogy. Again, a busy slide, but this is another major study called the Jupiter study, looking at primary prevention. So these patients had no chest pain. They were asymptomatic, men and women, slightly older, 50, 60, a large study, over 17,000 patients. And they had, the median LDL was 108, so not so high, less than that 125. And they randomized these patients to statin versus placebo. Now, the caveat here is they measured highly sensitive CRP. So they had a high hsCRP, which is a bad thing. It means they're inflammatory, like I explained to you before. But patients who received the statin 20, asymptomatic, had a reduction in the primary endpoint, 44% reduction. It's enormous. And death was reduced by 20%, significant reduction in all-cause death. That's incredible for a primary prevention study. This is the study called HOPE-3. Again, asymptomatic patients, lower number, 12,000, no coronary disease, no coronary. Again, patients in the 50, 55 and 65, men and women, and they had to have some risk factors which you will see in every patient pretty much at that age group. There won't be hardly anybody who doesn't have one of these risk factors. And they were randomized to statin 10 versus placebo. So no heart disease, you're excluded if you had heart disease. And look at it, 24% reduction in the primary endpoint. This is the hardest endpoint you can have. Cardiovascular death, MI, stroke, this is the gold standard of endpoints. 35% reduction risk in myocardial infarction. This is primary prevention. This is giving statins to patients before the disease process. Stroke reduced by 30%. Incredible. Reducing the risk of coronary vascularization by 37%. That's the need to have a Centaur and, God forbid, a stent put in. And this is exactly what I showed to my patients. Why is there a benefit of it? So on the left, these are called IVUS images. These are ultrasound pictures inside the coronary artery. And the patient here is at baseline before treatment with rosuvastatin, so that's statin 40. So you see on the top here with my arrow, you see this sort of cloudy area. And then below, it's just been mapped out in yellow. This is the plaque that I've shown you in many cartoons. And they measure the plaque area. And you see here, the plaque area is, if I can read the small print, it's 10 millimeters squared. That's the area. Now, this patient's now had 2 years of statin, and they've redone the picture. The person measuring this doesn't know who the patient is. It's a completely randomized, double-blinded procedure. Nobody knows anything about these patients. After 2 years therapy, there's a 42% reduction in the atheroma area. So this is cure. This is reduction in coronary plaque. This is treating asymptomatic patients or treating patients with coronary disease, getting their cholesterol down reduces plaque. Now their LDL went down to 61. We're often getting lower than that. But you see the benefit of that was a significant reduction in plaque. Again, a similar study is called reversal. Patients randomized to pravastatin or high dose atorvastatin, IVUS imaging before and after, 500 patients. And you can see that as the LDL goes down, the reduction in atheroma volume. And really, when you get down to areas here, so when you're lowering your LDL sort of more than 50, you see you've got significant reduction in atheroma volume. So there's a benefit to lowering your cholesterol. So I've been talking for about, let's see, 40 minutes. I'm going to wind up now. I'm not going to expand on all the future. I'm just going to give you an overview. We have a problem with our therapists. So I have touched on lifestyle. That is intrinsic to me, but I've focused obviously a lot on what I do, what I can offer. And what often we do is we have people on statins, but what's really quite frightening is that you see here on the left that 100% started on statin at year 0, about 50% less are taking them after 2 years. And that's often to do with these side effects. But on the right, we look at the statin trials and we look at withdrawals from placebo and statin, and there's really no signal of huge statin related side effects. So what goes on in the trials isn't happening in real life. And what we often think is that you have a preconception. I say to patients, it's like the state of Israel. The average person thinks it's a hideous, heinous, terrorist nation. So you mentioned the word Israel outside of Israel, and people already have a biased opinion of it. And it's very similar to statins. As you mentioned a statin, someone's doing to you like they do with Dracula, the dreaded cross, get me away, I'm not going anywhere. And I've heard stories about people growing tails with them. People's lives are ruined. They committed suicide. People have a really huge objective fear about statins. And here's what's called an N=1 study. So the patient is the control. And these were patients in this landmark study called the Samson study, actually from the UK. These are all patients who stopped taking statins. They just could not tolerate them. And what they would do over a period of a year, they were randomized to no treatment. So they weren't even given a tablet. Then they were randomized to a tablet, which was placebo. And then they were randomized to a statin. So obviously you knew for 3 months, for 4 months, you knew you were getting nothing. 4 months, you were getting something. 4 months, you're getting something. And amongst that something, you didn't know whether it was placebo or statin. And obviously the side effects reported were much less. Even still had side effects with nothing, which I don't understand. But anyway, people had side effects with nothing. But when you look at the placebo and the statin, there was no difference. So people were complaining about side effects because they were convinced they were on a statin. It was what we call the nociceptive effect, the fear of the side effect rather than the side effect itself. So after the trial, about 50% of the intolerant patients were then successfully restarted on statin therapy. So there is an issue. I'm not saying it doesn't occur, but we would roughly quote about 10% of patients would be intolerant of statins. And this is the reason why this is so important, is because the guidelines have changed. So any patient that we see who has, post-MI, post-heart attack, post-stroke, post-leg revascularization, so they have proper atherosclerotic coronary cardiovascular disease, the guidelines certainly in Europe and Israel say your LDL must be below 55 milligrams per deciliter. So that's these very high risk, must be below 55. Okay. And again, maybe you can see here, that's maybe why the blood tests show less than 100, but these are moderate risk patients. And if you have 2 events, we want the LDL even lower than 40. And this is a change from 2016 where they were slightly more relaxed, 70. So a lot of my patients, I want less than 55. And these are the drugs that we're going to see in the future. They are really going to revolutionize how we treat. So we have bempedoic acid, I mentioned. You've got drugs called the CETP inhibitors, evolocumab, and then these injectables as well. These are all part of drugs called ANGPTL3 and ApoC3. It's a lot of science, a lot of pharmacology, but in essence, these are very exciting therapies that are along the way. So going back to my patients at the beginning, I hope you'd all agree we wouldn't wait for the stroke. We'd start the treatment because it's a risk factor. It doesn't matter that the CT was normal. It doesn't matter that the angiogram of the cerebral arteries is normal. Who cares? They've got blood pressure. We fix it. It would be medically negligent not to. And the same here. This patient went on to have a CT. They have subclinical atherosclerosis, nothing obstructive, no requirement for stents or surgery, but they have the minor forms of disease present. So we wouldn't wait for the heart attack. We'd start treatment now. It's exactly the same process. The CT could be normal, in my opinion, but we should still lower the risk factor just as we do with the blood pressure. So for me, the future is bright, and I'll take any questions now for sure.
Thank you so much. I'm going to jump right in and ask a question because I have familial heterogeneous hypercholesterolemia, dyslipidemia.
Yeah.
My dad had 2 triple bypasses between the ages of 51 and 80 years old. And since my daughter was born, which was almost 18 years ago, about 6 months after she was born, I started statin treatment because I always had a slightly elevated or overly elevated cholesterol. And I was concerned about exactly what you're speaking about. I did have side effects. I was on a 10 milligram, at the time, I can't remember which medication. And then I was suggested to go on to 20 milligrams twice a week, which is equally as effective. But my LDL is definitely not in the range that you're speaking of. And it's very interesting to hear, your presentation today and to see the details. And I think it's definitely something that I need to take further because I'm doing everything I can with diet and exercise and being a dietitian, and sleep I'm very methodical about, and stress, I think there's certain things that we can control and can't control with stress. So I'm just interested to hear, from you today, what that LDL goal needs to be if I need to be aiming for 55.
Well, so it's a really, really good question. So, for me, I have in the back of my mind what the normal range is. And this is the problem. Nobody has defined the normal range for LDL. We know the normal range for blood pressure. We know that your HbA1c should be less than 5.7% because that's pre-diabetes. I'm certainly a person, I like to know what my targets are. I can't work in the abstract, but what's a normal LDL? Nobody knows. People will tell me what the normal LDL is. Oh, look, I'm only going on what experts say. I go to the European Atherosclerosis Society every year, and these really are truly experts in the field. And I think most people will acknowledge that the LDL should be between 30 and 70. LDL cholesterol is kind of a waste product of metabolism. It's really what comes from the VLDL, which is the triglyceride-rich lipoprotein. It's not something you need in abundance. And when you look at the big trials of these injectables, and you follow them through, there were people in those trials who LDLs went down to 7, 10, and they put these people in degradations, like I showed you in one of my studies, of risk according to how low your LDL went. And the lower you went, the better you were in terms of avoiding events. And it didn't matter how low you went. And the signal for subarachnoid hemorrhage, for dementia, it just doesn't seem to be there. There doesn't seem to. Now, I wouldn't go low. I'm not an extremist. I say, look, let's keep it in a range. 30 to 70 or 20 to 50. For you, with your, if you've got FH, the guidelines state that is a very high risk category, FH with another risk factor, but it certainly should be less than 70. And the trick that people miss is the ezetrol trick. You should really never give a statin without ezetrol. I virtually never do. And with the greatest respect to family doctors, they often undermine what I do because you get this sudden reflex of, no, you don't need that. And all I'm trying to do is avoid giving a high dose of statin because 10% will feel side effects. So what I would do in your case, I would have you on ezetrol first and foremost, for sure. But patients like yourself may benefit from going lower dose statin, 5 milligrams, just twice a week. But that combination of 5 milligrams of Stator, because it's a long-acting one, with ezetrol is incredibly potent. One of my secretaries at work, I started on Stator 5 milligrams a day. She lowered her LDL by 50%. You'll never see that in a textbook. But Stator 5 milligrams twice or 3 times a week with ezetrol is incredibly potent. And unfortunately, the coupons work exactly how I've said we shouldn't work. They will say, wait for your heart attack before we give you the injectables. We're not giving you the injectables yet. We'd rather wait. Foot, you get to your heart attack, no problem. We'll give you injectable then. With the greatest love in the world, there'll be no issue. But not until then. Just wait. You're not getting it now. We can't afford it. Let's get you hospitalized. Let's get that heart attack, 5-day admission, stents, cardiac rehabilitation, follow-up after. This runs into hundreds of thousands of shekels. But that injectable, no, we'll wait. It's frustrating. But the person who started you on a statin should be hugged and congratulated. It's a great thing to do. It's now just a question of tweaking with the doses. And then if I say to patients here, if you have private insurance, sometimes you have to go along that route to get the added thing, depending on how much your LDL is elevated, despite the adjustments in your statin ezetrol dose.
Thank you. I think I'll need to be in touch with you further.
I also have a question.
Yeah.
I actually have the same thing, but I was told that when you also have high HDL, if you take the statin just to lower your LDL, then your high HDL will also be lowered. And
it's a great point there. The HDL story is really interesting because there's a huge interest in raising HDL. And if you see on the previous slide here, these drugs are really interested in called the CETP inhibitors. And what they do is they interfere with the exchange of cholesterol between the good guy, HDL, and your bad guys, the VLDL and LDL. So you kind of, what CETP does, and maybe it goes back to that cholesterol is an energy molecule, and it's a shame to waste it. So it's a way of preserving cholesterol. The HDL gives up its cholesterol to the LDL and VLDL and gets triglycerides back. And these drugs increased HDL levels. So the feeling was that was the benefit, the reason why they would benefit, but it hasn't turned out to be the case. These drugs actually work because they lower LDL. Now, HDL is really your garbage truck. It takes the cholesterol back to the liver to clean it up. Now, you want to get rid of your HDL from the plaques, the LDL. Sorry, that's where I've showed you those pictures of LDL accumulation. So what the HDL does is to clean up. It takes away the LDL from the plaque and gives it to the liver. So in theory, if you can imagine your HDL is high, you'd say maybe it's dysfunctional, it's constipated, it's not actually doing its job, because a garbage truck that's full is perhaps not what you want to see. You want to see empty garbage trucks that have taken up the rubbish and got rid of it. So what we really want to measure is what's called the efflux capacity. It's the functional ability of the HDL. And all the HDL blood test does is just measure the amount of cholesterol in the HDL. So it's not really what we want. So I say to patients now, just ignore the HDL. It's a work in progress. We don't have the blood test yet, which will tell us the full picture. And now there's emerging data that high HDL is also associated with dementia. Like, if you have a patient with an HDL of 100, I don't think it's necessarily a good thing. We used to minus it as a risk factor. You say you can remove a risk factor. Now you've got an HDL. It's not the case. So I just say to patients, look, the jury's out. We don't use HDL as a marker now, but maybe in the future, because what we really want to measure is HDL function, and we don't have a blood test that will do that.
I wanted to ask with regards to triglycerides, because if VLDL is carried by triglycerides, surely that is a more potent marker.
Yeah. So basically, when we measure triglycerides, it's just a surrogate for the VLDL, and I can actually. So this is a slide I really like. That's kind of so when we look at the whole timeline of cholesterol, I say to patients, it's like we're in the liver and I'm cooking. God forbid I'm cooking. But anyway, what's actually happening in the liver? You're making a VLDL, which is a nice sort of blob of cholesterol and triglycerides. And then we pop a cap on it called ApoB. That's its sort of marker. So the VLDL, it has much more triglycerides than LDL cholesterol. It's what we call the triglyceride-rich lipoprotein. It's a fat triglyceride-rich protein. Apolipoprotein. And the triglycerides are a very useful substance. They're the fuel. The cells need them. So the fatty acids and glycerol, that's what's needed in the cells. So the VLDL leaves the liver, and the equivalent from the gut is the chylomicron. That's where your fat gets reassembled, and this is the chylomicron and the VLDL are the same thing, except the VLDL comes from the liver, the chylomicron comes from the gut. So how do we get the energy out of the VLDL? Okay, we go to the protein called lipoprotein lipase. This is so badly taught in medicine. We never taught this in medical school, but it's so important. Lipoprotein lipase is an enzyme on the endothelial cells, which basically takes the triglyceride out of the VLDL. So now the VLDL without the triglyceride becomes smaller, and the ratio of LDL goes up because you're losing the triglyceride components. And eventually, when you take enough triglyceride out, you get the LDL because there's much less triglyceride, but much higher LDL now because it's a ratio that triglycerides have been taken out for their intrinsic value, which is energy. So really, you can see the LDL is just a waste product of VLDL metabolism. But really, all these markers are just all atherogenic lipoproteins, because you can see here that on the green box here that VLDL, their remnants and LDL can all get taken up into if I put it now, all get taken up into the intimal lining. So these are all highly atherogenic, which is why I say to patients, your triglycerides should be less than 100, not 150. Once your triglycerides go above sort of 80, 90, your risk goes up. And what the risk of these triglycerides are is the cholesterol inside that particle. So that takes a little bit of thinking. So go back to this particle. The VLDL contains mainly triglycerides, okay? So when we get the blood test, we're measuring the triglycerides, which is a marker of this, but you've also got cholesterol in here as well. So the higher triglycerides, the more VLDL, the more of the cholesterol in this particle. These get taken up into the wall and they cause that inflammatory plaque. So that's why I wanted to explain the pathophysiology. It all goes back to the same thing, inflammation within the intima. And I think this picture is really nice because it just shows what's going on inside the lining. Now, when you have a lower LDL, it leaves and gets recycled to the liver. But like chaos theory, if you have lots of these particles, there's much more chance they'll get taken up into the intima. That's my theory of why LDL shouldn't be made to be low, should be normalized. Because if you have a normal LDL, you have less particles going into the intima, and a lower VLDL, similar thing as well. You make less LDL, less atherosclerosis. And states that you see high VLDL are your metabolic syndromes, aren't they? Your diabetes. Oh, let me get my little dog. Hold on a second. Sorry, it's a little cutie pie. So states that cause high triglycerides are your metabolic syndromes, your diabetes, overweight and obesity. And that's sort of, a really keen area, a huge area that I like to treat because it relates so much to this dyslipidemia. So you're right, triglycerides are a risk factor. They should be less than 100. And that's another area of confusion where they said 150 is the normal amount. It's really not.
And I just want to follow up with a nutrition question because, there's lots of, the research now saying cholesterol in food doesn't cause high cholesterol in blood. I just want to hear your opinion on that with eggs, for example, or, and then versus the fructose and the sugar being the reason for the causing high cholesterol, LDL.
Yeah. So I think that, when you, I think a lot of this goes down to, insulin secretion. The issue of cholesterol in the diet is a difficult one because, I take proactive statin and Ezetrol, and it keeps my cholesterol low. My son has 6 eggs every morning for breakfast, so I don't know what to tell him. Not that he would listen, but he has those every morning. I kind of go back to my original thing. I say, look, let's keep it real. For me, I'm going to send you to an expert in this, but as an interim, I just recommend a Mediterranean diet. You're going to have some cholesterol, you're going to have some cheese, you're going to have some, but it's a question of just keeping it in a sensible amount because you can't deny one food process. I'm kind of doing the keto thing at the moment, but I'm not purposely dafka eating huge amounts of fat because I don't really see the need to do that. But I think fat itself and cholesterol isn't a problem. I think you can have it, but just not too extreme. And I think that all those sugars and things, what they do is it's all about insulin levels, and insulin itself is an anabolic hormone. So if you have a high fat and a high carbohydrate diet, you'll release lots of insulin, and that fat will then become absorbed. It's the worst combination. So, that croissant is probably the worst, arguably the tastiest food you could ever have. Huge amounts of processed carbs with a huge amount of saturated fat. But yeah, I think that's, dietary cholesterol, I think it's okay. I think that your diet should have eggs and cheese in. I really do. But I also, I am also in the belief that people should be on statins from a very young age. So that kind of protects people and allows you to perhaps dabble a bit more.
I just want to ask a follow-up if somebody doesn't mind. You're talking now about insulin. I just wanted to know if you could, we know insulin is an anabolic hormone, but where does it fit into the cardiovascular picture?
Yeah, it's an interesting one. I think, I kind of always see insulin as the bad guy, but I don't know why. I think that there's yin and yang in everything, in every process in the body. I think that you need to have every hormone functioning and not dysfunction. So you're going back to that original slide. You want to have, genes, and then you want to have adaptive environmental responses. And I think that we've developed a lifestyle now where we are just hammering our pancreas chronically. Maybe not, there are people who have incredibly high sugar diets, but we have too much insulin and we're getting too much insulin resistance. And I think that's what the issue is. I don't think insulin itself per se, I think it's the lifestyle that we have that's causing so many issues of insulin resistance. You becomes, after a while, your levels go up and your tissue is just saying, look, I don't see you anymore. I don't see you anymore. You're just constantly there. And I think that that's the importance of any nutritional regime. I think it's switching off that level, lowering it, and adapting to a new kind of. And it's interesting because I speak to you again as the patient. And Alia knows this. I struggle a lot with trying to keep a sort of weight that I would like to be. And it goes in phases. And I've gone back to a sort of keto style diet, and I've noticed the benefits of it, because really although I was eating healthy for periods, it's overeating and kidding yourself thinking that it's okay, because I was generally overate, but not high sugar value foods, avoiding cake and chocolate and sweets, but I still overeat by an incredible amount. And that is what we're facing, I think, in the Western civilization. It's obviously, I have my own theories. I think the kids are eating way too much sugar. Both parents are working, especially in Israel. The larder, which used to be something unavailable to me, is now freely accessible to kids from a highly young age who are eating ridiculously high caloric foods. Mum and dad are out working and they come home, kids are alive and well. And that's the main thing, the fact they've had a packet of Pringles, a load of jelly sweets, that's not so important. The day to day, the kids are alive and well, and everyone's survived another day of, of chaos working and living in Israel. And it's like that in many countries. So I'll answer to your question, I think the problem is chronically elevated levels of insulin and insulin resistance.
Can I ask a question regarding perimenopause and menopause? Because that's, I think, where a lot of us are, certainly for me in my life and my niche as far as working with women at the moment. And I definitely see this increase in HbA1c and increases in cholesterol, regardless of like no changes to lifestyle. I had, in fact, a vegan client at the beginning of the year with a cholesterol that was off the charts, and which made absolutely no sense. And she retested it, and maybe there was an error in the test, but still her lipid readings were not what you would have expected for somebody who follows a vegan diet. So can you speak a little bit to that hormonal shift and changes and how you approach that, taking into account, hyperlipidemia as well as
I think it's a great point. Women have that protexia. We saw from that slide in the screening study in Sweden that women have this 10-year protexia. And I always say to patients, it's very interesting that Barbara Streisand has the heart center at Cedars-Sinai in LA, because I think she was just flabbergasted to hear that the biggest killer of women isn't breast cancer, it's cardiovascular disease. But women have been isolated from studies, isolated from trials. So the data on women has always been lacking. But for women, the biggest problem is cardiovascular disease, and when it's at that menopausal age. Now, something happens. And obviously, the easiest thing to say, it's that sort of fall in estrogen and progesterone, it's that triggers it. If it were that simple, we'd give everyone estrogen and there'd be no coronary artery disease. But something happens. And, many of you might have heard of this new blood test called LPA, lipoprotein little a. It's like the cousin of LDL. And in about a third of us, it's very, very high. And it's a risk factor. So it's something but unfortunately at the moment, we don't have an actual drug. It's coming in a year and a half. We don't have a drug. So we often lower the LDL to sort of offset that. And interestingly, we're told to measure it once in a lifetime, except in perimenopause women, because the reduction in estrogen, the LPA goes up. So it's another example. So things change in women when you get to that, Gila Mavar, when you get to perimenopause and menopause. Nobody completely understands why. It's obviously postulated it's a hormonal effect, but women suddenly become much, much more high risk. And unfortunately, in women, your risk of having acute coronary syndromes, once you get to the age of sort of 65, 70, exceeds men, whereas before that, it's always been way below men. And it's a really big risk factor. And women present differently. So it's a whole area in itself of cardiology, female cardiology. We have specialists now who are women's cardiologists, because women would come to the Muir and say, I've got back pain, and they'd be sent home and they'd come back with a heart attack. So in answer to your question, I think it's a really important area that, that's unknown. We don't know exactly why. It's hormonal related for sure. But the key thing to know is, we don't have all the answers, but certainly when it gets to that age, be prepared for changes in your risk factors. And we've got to be even more vigilant. Women need to be counseled more about the importance of nutrition, despite the fact that they're holding a good nutrition, but the risk factors will go up. But also exercise. Often women are always prioritizing their family. They're the ones stabilizing the house, making sure everything's working. They're the sort of key behind a successful household, and at the expense of their own health. So it's important saying, look, this isn't about making sure the ironing or the washing or the cleaning. I'm not sounding chauvinistic, but that's what certainly my wife does. She makes sure the house is perfect. I say it's not a question of that. If, God forbid, you had to have a therapy, and I hate giving this example, God forbid somebody has a tumor or cancer, nobody in their right mind would miss a therapy. Nobody would. Nobody would miss that. But hold on a sec. When you say, you know, did you go to yoga this morning? I couldn't at the time. Well, you go to yoga. Well, who's going to do this? Hold on a sec. What's the biggest killer in women? It's not cancer. It's cardiovascular disease. So why would you miss your therapy session? Why? That doesn't make any sense. You'd go mad with your partner, wife, son, child, you know, for missing, God forbid, a therapy session for something nasty. Why would you miss a sports session? It's your medicine. You cannot miss it. It's part of your daily process. You have to do it. There is no, I had something else in play. There was an important meeting. I had to get the house sorted. Who's going to do it? It's just mandatory because we're not winning this battle. You saw in the first slides, cardiovascular disease is going up and it's a preventable disease. And it's crazy that people are still coming to me in the middle of the night requiring stents to open up an artery when we could have fixed this before.
Is LPA measured in standard like Maccabi blood tests, or is it something that you have to specially request?
It's all standard. It's amazing. On this doctors WhatsApp group in England, I'm not even sure they're measuring it in primary care in England. Every single HMO measures LPA in Israel. Be wary of the units, and even with the same. So Maccabi always started measuring it in milligrams per deciliter, and Clalit in nanomoles per liter. Nanomoles per liter is the more accurate way of doing it. It's actually measuring the particle number, if you like, as opposed to just the mass. It's much more accurate. But within each coupa, they seem to keep changing the units now. So be aware, because if the number's high, it's not as bad if it's in nanomoles per liter, because it's acceptable to have up to 125. If it's in milligrams per deciliter and the number's high, that's probably a worse thing, because that's you know, the range goes up to 30. So it's measured by everybody. I make sure in every patient it's measured at least once. And in women, it may need to do it again. Sometimes the coupa will refuse to do it again. Sometimes you'll find someone's got 3 LPAs, and I'm not sure how they've got that by the HMO. But yes, you can have that in every single patient. It's just getting the GP to remember to tick the box. That's all.
Thank you. There was a question in the chat. I'm just going to read it. And you've already spoken about keto. Would you recommend a keto diet for a patient who's diabetic and has a high lipid profile?
It's a good, well, for me, that diabetic will be on a statin. That's you know, absolute. I mean, the trials are showing that diabetic patients should be on a statin. These are high-risk patients. And so in theory, yes, now I'm learning about keto. I only started it ad hoc the same day that someone at work was mentioning it. But it's not something I'm immune to. It's for me, keto is really saying, get your insulin down. And it's cutting out all the crap, and it's having sensible meals. It's not having no carbs, it's just having good carbs. But I don't go for, you know, I don't dafka eat burgers every night. I don't find that, you know, entertaining. I talk to people who do the keto and they're having lots and lots of burgers or that. That's not for me. I would recommend a keto diet, but the principle of keto being, again, it relates to a Mediterranean diet, that kind of food, but just cutting out the foods which don't have any intrinsic value. You know, we all go for a cracker. Fitness, I love that brand in Israel called Fitness. Every fitness product in Israel that you see has sugar in it. It's insane. It's so wrong. You know, fitness, kids wearing it's good. It's got a picture of a guy with a headband on working out, fitness, and it's got a load of sugar in the actual product. So yes, I would definitely recommend a keto diet, but on the caveat being, I don't think you have to dafka go so high fat. But I happen to like things like cheese and, you know, I like that kind of, I have chopped liver on a Friday night, I have cheese. You've got to get, you know, you've got to have an enjoyable lifestyle. If the nutrition, you know, preaching to the converted, if the nutrition is too arduous, it will be a temporary phase and they'll slip out of it. It's got to be something sustainable. And I think that keto style, high, you know, protein, a nice amount of fat, low carb, get rid of the shitty carbs. I think that kind of usually is sustainable because you can still enjoy your food. The difficulty I have with keto is no fruit. I mean, you know, that's difficult. But now I've noticed there are lots of products now you can buy. So you can buy ready-made stuff, which makes your keto life easier. We made a keto brownies, actually pretty nice. So when everyone's having a dessert, you can have the same. It feels like a proper dessert. So yes, I would recommend it.
I wanted to ask, with LDL, if somebody's at what, like you say, the ideal LDL is between 30 and 70, you know, somebody who, with what number do you say is okay, we need to start something? when you start a statin or intervention, medical intervention?
What range of LDL would I start? For me, anyone above those. So I kind of work in a sneaky manner. So if a patient's coming to me in the primary prevention, so someone could be you coming to see me. Now, sounds a silly thing to say. You're young, you look really well. I had someone like that in my clinic yesterday in Herzliya. I do a CT clinic. He came to see me yesterday. He's 48. He's been doing keto. He looks good. He looks like he trains as well. He looks kind of buff. He had the most horrendous coronary disease. I was so sad. It was horrible. We were chatting and he was going to come back in the room with the results. We were going to talk about keto recipes. I had to break the news to him that he might need bypass surgery. It was unbelievable. And he looked amazing. So looks can't be everything. So you come to my clinic and maybe your LDL will be 95. So, I kind of, so you say to the patient, look, you're not too bad. I'll leave you alone. Your car's not too bad. I won't fix it. The mechanic says that to you. You're about to give it to your son. He's driving to Rosh Hashanah tomorrow. And the mechanic says to you, it's not too bad. It's not perfect. I can't guarantee it's going to be, but it's okay. You're going to give that car to your son? Oh, you heck. No one's going to do that. So for me, your LDL is 90. I want to treat it. Now, okay, some say that's just crazy. Well, again, I'll go back to my example. Your blood pressure is a bit high. Am I going to treat it? No, wait for you to have the stroke. It's a question of minimizing the risk factor to prevent the disease. Now, I say to patients, look, I'll answer your question. I would treat you, but very gently. I might give you Stator, and this may be one example where I don't use combination. I might give you Stator 5 milligrams twice a week on its own because you're so close to, normal, but you're not normal. So I want to get you normal. And I say to patients, just tell me, run it by me, how many insurance policies you have, and run it by me when you go to the next world, how much you'll have spent on them and how much you got back from them. So I'm thinking I'm paying every bloody month in England, I'm paying £90 for my critical illness. It kills me because I don't earn English pounds. But God forbid something happens to me, I want that money for my family. £90, it's not a small amount of money. I'm paying money for car insurance, I'm paying money for health insurance, I go on holiday. The block of flats I live in, I'm pretty sure I could leave my door open for 10 days and I'm pretty sure nothing would happen. It's a small, safe block of flats. But am I going to do that? No, I take out all insurances. And when I get to the pearly gates, I pretty much never have claimed on them. So again, to say the same for you guys, for all of my patients, we'll give you some these treatments. I can't guarantee that I definitely isn't, but on a population level, of course, this is the right thing to do. I can't guarantee you, only he upstairs knows who needs it and who doesn't, but you go on the balance of risk to reduce population risk. So in answer to your question, I try and treat everyone above 70. Now, with someone like yourself, I would say, look, you're young, you are intelligent, you know about the importance of lifestyle. Let's go and do a good. I send a lot of my patients to Aaliyah. I'll get it. Go for it. You want to do healthy lifestyle? I'm all with you. And then we'll meet back in 3 months, 4 months, and we'll see. Let's give you a good trial. And if it's still high, I say, okay, well, I've done it your way, you do it mine. Let's just try a gentle amount. Stator 5 milligrams, or even ezetrol on its own, and then get the LDL down. And for me, that is a preventative strategy because at the age of 40, I'm stopping that cumulative exposure. And just one thing I wanted to show, I use my analogy of exposure to the pension plan. And I say to people, when you are starting, I remember when I became a doctor, the first day, we had all these organizations that would come to the common room, we'd go through stations to meet with them, and one of them was starting your pension. And obviously, nobody wants to see your money leaving as soon as you've got it, but you don't bat an eyelid. You start low, small amounts each month, and when you get to the fine age of pension, you have a big pot of cash because you've cumulative invested money. It's exactly the same with cholesterol. It's a cumulative exposure. And the sooner you stop it, the sooner you lower the trajectory of that cumulative exposure. And it's the same with a pension. You start low, you accumulate low and slow. You start high, you accumulate slow and high. So you get a bigger pot at the end. And that's the problem with that. Yeah.
Sorry, are there any supplements when somebody says, oh, I'm not ready to start the statins, I'm going to try, nutrition, exercise, sleep, stress. What could I take? I want something natural.
Yeah, so there are, and I'm certainly not against those. I always say to patients, because I'm not an alternative, I can't actually endorse them. But if you read in the literature, so there's red yeast rice, which actually contains a statin in it. It's just a natural statin. It's actually a sort of pro-drug form of lovastatin, which was the first statin that ever came. So it's called red yeast rice. And that's something you can buy in the shops, and it does lower your LDL, but it's essentially a statin.
You have
And
to
then
take
you've got
it at a
other
high
things.
dose.
Sorry?
I'm so sorry, you have to take it at a high dose. A lot of the supplements are at a lower dose, but the dosage is important.
Yeah. Okay. Well, again, I don't have that. I know that sort of berberine is touted as another one, and garlic, and so and by the way, I'm certainly not against that. Our drugs come from nature, so I don't see any issues with alternatives. It's just I don't have.
What about higher doses of omega-3, like between 3 and 4 grams in order to bring triglycerides down?
That's a really interesting. So I have my own feelings that, because we have a drug now that's so when we look at the omega-3 story, it's really interesting. And what you buy in the shops is a combination of EPA and DHA, the two omega-3 fatty acids, and they are FDA approved as a food, not a medicine. So what these actually come from is a mass-produced product where the fish are used to make it's animal feed, the fish oils, and then you take off some of that to go into the sort of pharmaceutical world. So to make pure omega-3, and the one that's been studied that has benefits for the heart is the EPA. All the trials of mixed EPA and DHA are a graveyard of failed trials. None of them have shown a signal of any kind of benefits in the mixed. Now, we believe that DHA is probably good for cerebral brain development, especially in babies, and EPA is the one for hearts. So when the trial came out of a drug called Vascepa, it's a highly purified, high dose, 4 grams a day of pure EPA. And you can only get that on prescription. And there's a famous study called Reduce It, which showed enormous benefits in high-risk patients with that drug. And it, as often happens, as I said to you, cardiology is full of egoists, that a war started between two very big American cardiologists because one found the trial successful and the other one did a rival trial, which was negative. And wow, it started a war of all wars. But EPA on its own, pure, I'd recommend. I actually tell patients do not take omega-3 because lots of studies from the groups looking at the sort of cellular effects, and it's shown detrimental effects, that it can even be pro-carcinogenic because the omega-3 gets oxidized by light and there's no quality control here. So to make pure omega-3, it has to be in a light-free environment. And what we have is a mass-produced food that isn't done to any high standards. I'm not saying there aren't high standard ones, but I don't think we know which ones are really pure. And so I said to patients, they're very expensive. Without evidence, I wouldn't take them. And if your triglycerides are high, you need a workup for that. And if it really is due to insulin resistance and diabetes and overweight, the best treatment for that is, lower your alcohol levels, get fit and change your nutrition. And that can lower your triglycerides by a huge amount. And for the moment, I wouldn't take omega-3 supplements. And maybe one day the Vascepa will be much cheaper and available sort of to more people.
Thank you. That's actually really fascinating because dietary guidelines, especially for high triglycerides, recommend, if you look at most countries, with Australia and Canada and here, they all recommend between 3 and 5 grams. So they are finding that really, really fascinating that perhaps, the dietary guidelines need to be amended.
Recommend what 3 and 5 grams of what of omega-3.
Omega-3, yeah.
If you do it, there's a lot of meta-analyses of the mixed preparations, and really there's no trial that shows a convincing cardiac, looking at hard endpoints. There's no trial that shows any benefit for mixed. So it's, these drugs are, you see them in the shop, that the more expensive they are, as long as it's got a flag of Denmark on, you think, oh, this has got to be good for you. And really it's an unknown bag of what you're taking. So I definitely say to patients, don't waste your money. I'm sure they're not cheap. And unless you can really prove, maybe some of the vegan ones, I don't know, but it's a food product. It's not subject to drug recommendations and stringent checks. So you've got to be very careful with them. And I think that, triglycerides are super sensitive to lifestyle.
Can you take red yeast rice together with a statin?
Well, you definitely shouldn't, because you may get, you don't know what the level you're getting to. You probably could do. I wouldn't recommend it. but you probably shouldn't do because you don't know what the interaction will be. It does depend. So say someone's taking Lipitor 10 or Crestor 10, I don't think there's a problem there, because the extra red yeast rice you're taking is not going to be more than, say, 30 milligrams extra of Stator, and that's allowed dose. 40 milligrams of Stator is the allowed dose. But because, you know, the patient is unsupervised, I would tend not to. Now, obviously, if you were my patient as a nutritionist, I would probably maybe have a different outlook on that. But as a whole, I think that the societies would say don't combine the both. And even on the red yeast packet, it may even say don't have or caution if you're on a statin.
Thank you. This was so fascinating.
Sorry,
thank you so much.
Before you go, sorry,
Yeah.
I just wanted to ask about calcium supplementation, because with, you know, osteoporosis in women, you take more calcium, but calcium produces, you know, contributes to plaque. So like, how do you manage calcium?
Yeah, so I say that, you know, the calcium in the plaque is a side effect of inflammation, and the calcium you take doesn't seem to have any impact on that. And obviously the impacts of osteoporosis and osteopenia are so profound. You should definitely follow the advice of your nutritionist, endocrinologist, and I don't see any problem with taking those supplements at all. I mean, often
It sounds, sorry, I just interrupted, but it sounds like a lot of the time you're saying like it's actually managing the oxidative stress and the inflammation.
Exactly. That's why I think it's so important to think about the disease processes. So the calcium you ingest, you know, and obviously vitamin D is important as well. It doesn't have any impact itself on the calcium. That they're two separate disease processes. One doesn't drive the other. So you can take calcium supplements and vitamin D and everything you need to prevent osteoporosis and osteopenia, and at the same time work on your cardiovascular prevention. But the two are separate processes in my experience, in my opinion.
Thank you so much, Dr. Paul. I personally need to run now because I've also got a client, and we've taken so much of your time. But it's been extremely informative. And as you can see from the questions, we probably could chat to you for another 5 hours, not run out of things to ask. But thank you so much. And if it's okay with you, we'd love to sometime in the future invite you to continue the conversation.
Yeah, for sure. No, for me, this is not this is education, and it's about all of us, you know, growing together and working as a unit. But you guys are my first line of defense, so it's really important we do this. I think as an army to defeat this this process of cardiovascular disease. We need to get rid of it. It's a nonsense disease. We can prevent it.
Amazing. Thank you so much. We really appreciate it. And thank you for allowing us to record it. I'm going to share it with all the other dietitians who weren't able to join. And we look forward to having you again for further discussion.